Good morning, everyone, and welcome to the main session of the Healthcare and Pharma track of EBDVF. And I would like to thank the speakers and the audience for joining today and the moderators. So this session will be moderated by Milan Pektovic, Head of Connected Care, Data and AI Innovation at Philips, and Flavio Fuart, which is Consultant and Project Manager at the Chamber of Commerce and Industry in Slovenia. I will give an overview of the session now, and I will present the keynote speakers and then the panelists, and we start with the presentation and we continue then with a panel discussion to deepen the presenting aspect and answer the relevant questions from the audience. So I also invite the audience to take part to this discussion by interact and asking questions. So this is the main session of the Healthcare and Pharma track of today, and is followed by also relevant session that I invite you to join. In particular, there will be a session later related to the eBrains project and another session organized by BDVA related to the realization of AI in healthcare. So I would like you also to, I would like to invite you to join this session. In this session in particular, we'll explore how healthcare data space can facilitate data access and secondary data use. So we know that in most European countries, AI applications are transforming the healthcare and pharma sector. However, data availability remains a limitation for research and policy making purpose. So we would like to discuss upon rules for accelerating data access and upon aspects related to data donation, as well as open data in the healthcare and pharma sector, and possible roadmap for European health and pharma secondary data applications. So we all know that secondary data are actually great, they have a great potential to improve healthcare and health outcomes, but we need a good harmonization among protection, data protection of secondary data and facilitation of their reuse for research purposes to leverage innovation. So we will tackle this bivalent problem of data access and its impact on privacy and confidentiality. I would like now to introduce the keynote speaker. Our keynote speaker is Carrie Thompson. Thanks, Carrie, for joining this session. Carrie is a Deputy Head of EHealth Wellbeing and Aging Unit in DG CNECT, and she's working in a digital transformation of healthcare, as well as in the development of European health data space. Before joining the European institution in 2002, Carrie worked on global health policy at the UK's Department for International Development, for KPMG's International Health Practice, and on epidemiological research project in UK and in Brazil. She has a degree in mathematics from Durham University and a Doctor of Public Health from London School of Hygiene and Tropical Medicine. So, Carrie, thank you for joining this session again, and I will give you the floor.
Thank you very much. It's a great pleasure to be here with you all this morning and to deliver a keynote speech about what we're doing, really the view from the Commission in this area. So I'm just going to share my slides with you now. I hope that you can see them. Do I have a nod that these are visible? Yeah, great, super. Thank you. So indeed, so let me just dive right in. So I mean, absolutely. So we're working really on the digital transformation of health and care, and of course, a part of that is the development of the European health data space. And this is really the framework and the key objectives that we've been working to since 2018, and they're still very much the same. So I think they're worth pointing out. One of which is that we're in this in order to really, help citizens to get better access to their healthcare data wherever they are in the EU for whatever reasons they wish to have it. That was what we're calling the primary use. We're also keen to make sure that we have data to connect and really share data to create better data for digital, so we can apply them to this next generation digital tools, artificial intelligence, and so on. And to really sort of boost research and innovation in various areas, and that's what we're calling kind of secondary use. And then the third really part of the equation is about really making sure we've got a digital single market so that it's easy for digital service to be easily transferred from one country to the other. And just to give you, as we're on the kind of high level framework, what the kind of political layer is saying about all this. So, of course, Stella Kyriakidis, who's leading on the European Health Data Space, announced that we really need to make the most of the potential of e-health. We want to provide high quality healthcare, reduce inequalities. We're going to work on our European Health Data Space. We're going to promote exchange and research on preventive strategies, treatments, medicines, medical devices and outcomes. And it's important that we ensure that citizens have control over their own data. Commissioner Breton, who is our commissioner from DG Connect, both of course for digital policy and also for innovation and for single market, he has said, of course, I want to see European businesses and our SMEs access the high quality data, create value for Europeans, including through the use of artificial intelligence applications. So we know in all this, regardless of sector, health or any other sector, we know there's a huge number of challenges that we have to address across the EU. At the outset, we know that there simply isn't that much data. I mean, not enough data is being reused, whether it's coming, particularly that coming from and relevant for the health, when we're talking about the data held by public sector, of course, where much of the health data is generated. We also know that across the EU, we need to improve on how data is being processed and stored, and that's obviously particularly a problem for the public sector. We know that there's a lack of governance. I mean, this is all sort of brave new world territory. So we haven't set up the governance for these kinds of procedures. And when we're talking about sensitive data like health, this is obviously critical. And at the same time, part of the need for governance is also around addressing having the technical tools in place and interoperability and so on. We know that we need to improve skills and literacy. We know that we need to do work with member states to make sure that there's similar rules in each country so that we don't have the fragmentation. And we actually, at source, we need to boost people's awareness of all this so they can really feel empowered. So the digital strategy that was launched last year aims to really tackle, broadly speaking, put in place a number of pillars that will improve this across all kinds of data, health included. One is about putting in place the broad horizontal governance that can apply to all kinds of data. So this is the work that we're doing, and I'll just come to that in a minute, on different kinds of data acts that we're developing right now. The second sort of pillar would be around really huge investments in between the Commission and the member states in what we're calling enablers, so large pieces of infrastructure that are really about helping the data flow and then helping it to be used and helping it to be exploited. This could be in terms of supercomputing or cloud infrastructures. And of course, in this area, we know of other large initiatives that are out there with very similar aims, such as the GAIA initiative on cloud use. They're all going to support that these large infrastructures are in place. Another pillar would be around, big investments under various programming bodies to really support the programming spending programs to support investments in competences in a very more systematic way across different sectors. And then the fourth pillar is about the development and creation of these different data spaces that we're talking about. And then obviously we're interested in the health data space today, so I'll talk a bit more about that in a minute. But just in terms of the legislative, the horizontal layer, you can see here there's a slide just showing a number of the different acts that we're some of we have come out with the proposals already. The Data Governance Act, we have already come out with a proposal, and others are ongoing. The Data Act is one that should come in the next few months from us. And these are all, as I say, horizontal, so that they're applicable to all kinds of data, but that also includes health. So if I can just focus a little bit on the Data Governance Act, the proposal we published in December 2020, and it's addressing, or November 2020, and it's one of the things that it addresses is the sensitive health data that's held by public administration. So we could think of hospitals, for example, and other healthcare providers. And in its chapter 2, for example, it leaves room for member states, but it requires that they create at least one contact point per member state to act as a liaison point between those actors that are holding this data and those actors that are wishing to use this data. And this is based on inspiration that we've seen in some member states already, such as in Finland with FinData and the French Data Hub, where they put in place national entities with a role to really support curate the health data and respond to the requests that are coming in for the data. And then we could look across and we could see potentially that these could also have a role in cross-border sharing of data. And then the chapter 4, I think is also relevant to mention briefly, of the Data Governance Act allows for setting up of data altruism entities. So creates a way in which countries can set up and regulate entities that will allow people to donate their health data, providing certain protections are in place for this. And this can be another way that we can boost what data is out there for innovation and research. And then of course we come to this particular piece of work that the Commission is working on at the moment, developing a proposal for a European health data space, a legislative proposal, which you can see as then will be legislation that will sit atop this horizontal legislation and be a kind of lex specialis for the health data. And again, here we can see very specific problems in the health data space, mirroring many of the general problems around. We know that people don't have much access to their data. We know that there's a lack of interoperability. We know that that it's difficult to access cross-border in a safe and secure way. So we don't have sort of coherent infrastructures in place. They're quite fragmented. We know a lot about the issues around the single market. We know that we've got an uneven legislative framework between the member states, which is causing a lot of problems. Quality issues are different between member states. And in terms of the artificial intelligence that we want to really be exploiting with the health data to get the potential out of the health data and really sort of lead to the next generation of treatments, then we know that we need to have clear rules in place there. Around, for example, how do we actually train data on AI? What happens when they're used in situ in a hospital? What happens if things go wrong? So in all those areas, we're looking at these from the context of the proposal. So what could be appropriate governance? How do we develop the quality? What would be appropriate infrastructures? How do we eliminate barriers to trade and to the single market for digital health tools and services? And how do we develop AI in this sector, the use of AI in this sector? And here's this sort of wanted to show this how we're kind of conceiving of a lot of this, how we're kind of conceptualizing this kind of thinking. Of course, we're talking about the primary and secondary use. We're talking about the need to really simplify create mechanisms and really simplify how we can exchange and create access to different kinds of data. Whether it's for better healthcare in the treatments, whether it's for policy making, whether it's for research and innovation. And we're looking at, as I mentioned before, in those particular areas around looking at the governance, looking at the quality of the data, promoting how we can promote fair, the data is findable, accessible, interoperable, reusable, how we promote these mechanisms. How can we, what is the right infrastructure? How can we promote the infrastructures and how can we develop capacity building? And on the infrastructure side, this reference, by the way, to EHealth DS2 is something, a shorthand of expressing that it's about the secondary use side, rather than the primary use side. On the primary use side, there is an emerging infrastructure in place. It was called EHealth DSI, and now it's called My Health at EU. It had a rebranding. And it's already, many member states are involved in this. It's already countries are starting to exchange patient summaries and e-prescriptions for patient use and clinical use across the member states. And so, but we don't have anything in place for the secondary use. So we're setting up a pilot project. We set up a pilot project that will work for a few years to test what we can do for secondary use and what would be the right mechanism and which actors to involve. So this is a project that's ongoing and it's funded by the EU for Health programme. And then, of course, all data spaces and of course, health none also, we're going to rely that there are technical tools in place, because the key aspects are going to be, of course, interoperability and how do we get the data linked across borders. So a mechanism that is separate to the eHealth data space, but will, of course, link up with it, legislation that's coming, but is very much linked up to it, is a recommendation that we adopted last year, where we said to member states, you know, it's really important that you develop and adopt common technical standards for different kinds of health data. And we set down those that were already in existence around patient summaries and e-prescriptions. And we proposed that, okay, the next significant lot to work on need to be lab test discharge letters and images. And then we got agreement on this from the member states quite quickly through the eHealth network. And then we've put in place a project that's actually largely composed of many member states, and it's doing that very kind of time-consuming work of developing these technical standards, and we expect them to come out with draft technical standards by autumn next year. And then, you know, I hope there'll be an opportunity then to update what is the consensus around these standards, and then we will, I think, move on to other health domains, because this is going to be work that will continue. And this is obviously a lot of different kinds of health data that needs to be developed. So I mean, a lot of this is going to be funded through various programs. I'm going to just focus on EHealth program, for example. We've had the Recovery and Resilience Facility. We've got the various structural and regional funds, which are all mechanisms that member states can support their investments in these areas. I wanted just to focus a little bit on the digital program, because we've just published this month the first work program for that on the 10th of November. And, you know, across the work program, I'm focusing on this slide on the health aspects, but across digital are significant investments in all the major infrastructures that I was talking about: cloud, supercomputing, artificial intelligence. So we're talking about cybersecurity and so on. So just for the first 2 years, we're talking about nearly 2 billion worth of funding. And of course, I mean, we've got specific work programs out there. We've got a general work program. We've got one particularly focusing on cybersecurity. We've got one particularly focusing on setting up what we're calling digital innovation hubs. And health, you know, then is also a really important deployment area. And this sets out roughly what we're going to do for the first 2 years. And you can see we've already got calls open in genomics, which I'll talk about a little bit later. Also in promoting the uptake of digital solutions in health and care, developing a community that can help do this, and also developing an ecosystem for digital twins in healthcare, which I'll talk briefly about as well. And then in secondary call, I'll mention as well something called a cancer imaging initiative that we intend to come out in the second call, and also something around testing and experimentation facilities. And there'll be a separate strand on cybersecurity and trust, with a particular action on health that's also in the first call. And this first call is now already published, so these calls are already open. And the second calls we expect to be published, I think, round about spring next year, 2022. So just looking at some of the specific actions, I mean, one of them then is on testing and experimentation facilities. So these are intended to be really large-scale facilities focused on specific sectors. So there will be specific facilities focused on the health sector, where an innovator can come. They can have access to all the kind of the data that they need. They will have access to all the kind of infrastructures that they need, whether it's artificial intelligence, or high performance computing. We'd link it, perhaps, for example, to an artificial intelligence platform. We would make sure there was the mechanism could be that an innovator, let's say it's an SME, they might go first of all to a data innovation hub, which are complementary to these facilities, in that the innovation hubs would be regional. And the innovation hub would say at a certain point in the development of your product, in fact, just prior to entry on the market, you may now need the services of a testing and experimentation facility, and they could direct them towards this facility and how to use them. And then at this facility, their product, would be able to run through the final tests it needs to then enter the market safely. So it would, as I say, it would have access to excellent quality data, sufficient scale that it can do all the fine tuning it needs to do. It would also have access to real world settings. So talking about health and care, we're talking about then access to patients, access to clinical environments. And so we want these to be really world-class facilities that innovators can use. An initiative that we'll have then in the second call is called the European Cancer Imaging Initiative. And this is one of the initiatives I want to talk about, which is really about creating the data. So much of the work around the EHealth DSI and the My Health, My Data and the legislative proposal will really support the linkage and the creating the data around electronic health records. But of course, there are many other kinds of data as well that we'll need to really develop the kind of the collection, the availability, the accessibility, and then in time link all these data, different kinds of data together. So something we're particularly calling the European Cancer Imaging Initiative. We put it as a flagship digital initiative into the European Beating Cancer Plan. Again, we want this to be a kind of state-of-the-art platform for innovators, focused particularly on those products that will use images of cancer. We've got a portfolio of Horizon projects that are ongoing, about 5 projects with a combined investment of around 50 million euros, each looking at developing stores of different kinds of cancer images, and each looking at the challenges to linking up this data with getting them working with AI algorithms, thinking about how to safely store them, thinking about how to safely link them. So that the idea is that those are Horizon projects. So through this investment, through digital, as digital is a deployment program, we want to take the work out of the research setting and then deploy it and create something more sustainable. So link up the kind of work that's being done, create what we're calling an atlas, by which we mean images with a geographical spread, connected cross-border, and of anonymized images as well. So this means that they would be able to kind of move more easily than those that are subject to the GDPR, because if there's anonymization involved, there may be more flexibility with anonymized images. So obviously all part of the process. And link these to the testing and experimentation facilities, and then have this as an excellent source of imaging data, so we can really test this whole approach using cancer images and really boost innovation in this area for the benefit, of course, of patients and ultimately. I think you're all aware, or you may be aware, another piece of work, and I mentioned this as part of the first call, the call for this work is out now, but this is the work that we're doing also to generate and really improve the accessibility and secure accessibility of genomic data. It links back to a declaration for 2018, where member states signed a declaration agreeing that by 2022, so that's already next year, we would have accessible 1 million genomes securely to member states. And then the idea after that is quickly to ramp that up to about 10 million euros. So member states we now have 24 signatories. So most of the member states are signed up to this, and those that haven't signed are participating in meetings and very interested. And the idea here of course, they've been working from scratch. So there was nothing in place. Of course, countries have national programs, but there was nothing in place to think about how on earth do we do this across border. So they've been working since then on various aspects of infrastructure, of the governance, of how to make the trust frameworks work, what are the ethical issues involved. And we've got to the point now where with the launch of the digital program, we will actually start the deployment of a federated infrastructure that will enable this data to be linked across border and made accessible, alongside looking at governance aspects and access issues. Lastly, just on digital twins, this is something that we've also called it. I think it speaks to a promise that is a very exciting area across Europe. There's a lot of work going on in different research areas across Europe, looking at different aspects of virtual representations of parts of the human body, like different organs, like the heart, for example, and the brain. And the work that we want to do at the moment is to make sure that there's a sort of underlying framework for this work, so that in time, when it reaches the right point, we will be able to connect all these isolated centers and make sure that we can bring this work together towards the full virtual simulation of a human, the human digital twin of some kind. So the work here we want to do really is about, because it obviously has huge promise in terms of clinical work, in terms of development of new treatment approaches, and we want to really map the ecosystem, support the ecosystem, put in place the linkaging, the integration tools that they're going to need, so that such as could be a best practice platform, so that we can really make sure, as I said, that these isolated centers of work connect well in future and whenever they get to that point, which we think will be soon. So that was my run through. I really hope that was not too long and gives you an overview of the various things that we're doing in this area. Absolutely happy to answer questions in the course of the pandemic, in the course of the session, the panel. Thank you very much.
Thank you. Thanks, Carrie, for your great contribution. Yeah, I see already a question from the audience, and yeah, I look forward to hearing your answer later during the panel. I also encourage the audience to write down the questions to the keynote, to the panelists that will present now their intro and problem statement related to the objective of this session, and I can bring later the question to the speakers during the panel. So now I would like to introduce the speakers for this panel. The speakers will give an introduction related to their roadmap and strategy and view on data access and secondary data use. And later we'll answer the question from the moderators and the audience during our panel discussion. So first of all, today we have Moisa Svirn. Thank you, Moisa, for joining this session. Moisa is a training manager and expert community development specialist at SRC Infonet. She's actually involved to understand the digital transformation in healthcare, and in practice, she has a strong track record in project management in the field of digital health, focusing on the digital transformation. She's a member of think tank at healthday.si, which is a community of health tech innovators and stakeholders. And what I like from Moisa, and I really thanks her for joining the session today, is her persistent advocate for better healthcare, which I can see in her bio and track of records. Thank you, Moisa. I look forward to hearing from you the contribution to this session. Then we have Bert Verdonk. Bert is a program manager at GAIAX and Philips. Thank you for joining the session, Bert, today. Yeah, Bert is involved at Philips to explore the European health data space initiatives to improve health data sharing for primary care as well as for secondary use and research. So she's really contributing to the GAIAX project to build up a European data ecosystem. He has a background in image processing and clinical application with a PhD from Telecom Paris, and is actually involved at Philips in advanced development product management. So he led various teams in product management, marketing, sales, and business excellence. And he was also in charge of the integration of Vita Health into Philips. So he's close to several positions like R&D management and general management. Then we have Nicole Arming from Roche, Slovenia. So Nicole is a general manager since 2 years of Roche, Slovenia. And yeah, his role is related to integrating diagnostic medicine, but also healthcare technology and data analytics under one roof. Before this role, she has also worked on the global pharma strategy at Roche. So she will bring the point of view of a pharma industry to this session. And she has also several experience of advising and leading global biopharma and medtech companies on their own strategies. Then we have Ricard Martinez. Ricard Martinez is professor at Department of Constitutional Law, Political Science and Administration at the University of Valencia. Thank you, Professor Martinez, to join this session today. Yeah, your contribution is really appreciated as a legal expert and legal point of view. Is as Doctor of Law from the University of Valencia, and he has dedicated his research to study the right to data protection and all the issues related to the impact of information and communication technology in private life. He's part of the working group on digital rights of citizens of the Ministry of Economy, and he also supports the European Horizon 2020 project as a big Medilytics. So thank you to the speakers to join the session. And now I will give the floor to Moisa to start with their introduction related to the her contribution to the session.
Thank you, Francesca. Thank you very much for a really nice introduction. Yes, and as you said, I work at CertSinfonet. We are leading software vendor in the Slovenia healthcare system. And our core can be described as digital transformation of healthcare provider organization. That's what we support. We are a team of 90 experts who developed specialized and very complex solutions for supporting all the processes in hospitals, in primary care, also in private clinics and some other organizations like care homes for elderly, etc. And our program supports the patient journey throughout the process, from admission to discharge, diagnostic, treatment processes, etc., etc. And beside this hospital information system, we are also offering other healthcare solutions, ranging from mHealth apps, communication platforms for communication between patients and doctors, to development of public e-services such e-prescription. We truly believe that healthcare of tomorrow is based on synergy between ecosystem key stakeholders. So we work closely with other IT vendors as well. And over the recent years, we have partnered or integrated more than 300 different healthcare tools, solutions. And we were also partnered at large national projects. I believe this statement is also very in line with the initiative of EU Health Data Space. And I believe, therefore, I will also, I was invited to contribute today. I was specially asked to somehow shortly present where we are standing in Slovenia in terms of public e-health. And I will give you just a short glimpse into where the data is collected from and what Slovenian public e-health actually provides. We have a public healthcare systems, which covers most of medical services, including GP consultations, emergency and outpatient hospitalization, most of med specializations, medication prescriptions, etc., etc. We have 3.1 doctors per 1,000 patients, approximately 92 public institutional healthcare providers, out of which are 27 hospitals. Then we have approximately 11,000 doctors. We have a health ID number per patients already. And in the market, there are, let's say, approximately 20 healthcare system or hospital information system solution providers. I would say that e-health project started, as far as I remember, back in 2008, and is nowadays managed by National Institute for Public Health. E-health services are available to all healthcare providers, primary, secondary, and tertiary, and also to citizens. We, as citizens, we can access the limited set of healthcare data via Zwem app or portal. And what is of more interest is actually that most of medical data sets available in national platform are transferred to the eHealth backbone via local information systems. And currently, is available quite a range of eHealth services like e-prescription, e-appointment, e-referral, central registry of patients' data, patient portal, and mobile app for citizen, electronic immunization registry, teleradiology, telestroke, etc. But the current volume of the data collected in the CRPD depends on the extent to which is actually entered by healthcare providers. And one of the most important informations are actually patient summaries. Well, we are lagging behind in that regard a bit, so there is not so much of those data yet, but altogether, there is 23 million medical documents like different PDFs and unstructured data, 6 million COVID test results, 16 million appointment records, 54 million dispensed medication, 10 million transactions via app supporting mass testing and vaccinations, etc., etc. And if we put all this together, I believe there is some potential to contribute to EU health data space as well. And according to some latest records and analysis, I believe in other regions is the same. And we are looking forward to joint initiatives and joint data space very much.
Thank you. Thank you, Maisa. Yeah, let's discuss later about the details and asking you a question related to your statement and introduction. So now I will invite Bert to present himself and his roadmap related to the mentioned topic.
Okay, thank you. Let's see if I can share this small set of slides. So thank you for organizing this panel and for the invitation. I want to talk about from 2 points of view. So I will start with a perspective from the GAIAX initiative. Philips is an active member of GAIAX, but we're not alone there. There's more than 300 official members and even a lot of non-members who collaborate between industry participants, but also research institutions, either private, governmental, or academic. And we have actually a very rich collaboration amongst ourselves about data spaces at large. GAIAX is a multi-sectorial, industry-driven initiative where we think about the governance, the organization of how do you set up a data space, but also about the technical frameworks in order to do so, the architecture in order to do so. We actually closely collaborate with other associations in this domain, just like BDVA, but also FIWARE, the International Data Space organizations. And I hope from an industry perspective that we are really converging our ideas, our thoughts, our initiatives, underpinning and supporting the development of the data spaces. So we're very happy to see the legislative drive from the Commission, from the member states, and we try to complement it in a synergistic way with the latest ideas, thoughts, and insights from these industry associations. So what is GAIAX doing? We want to create federated, we heard that word before, federated health data spaces at the regional, national, and European level. Nobody longer believes that there should be one central repository, and we're not in a big brother age. We know that data will be aggregated in very many places, in very many databases and repositories, but we need to find ways to combine that data between institutions at a regional, a national, and a European level, because that is what our society needs. In order to do that, it needs to be trustworthy. And for that, it needs to be compliant to a good design, privacy by design, security by design, usability by design, such that people can really trust this infrastructure and that they can build on it and adopt it easily. In essence, what we try to achieve with the framework is to achieve sovereign control of data and data flows by the patient or the citizen, because that's where the ultimate control needs to be in a much more usable way than before. In GAIAX, we have worked about these ideas in many industry verticals, and they are actually published on our website in a number of position papers, and there's a pretty detailed health position paper worth reading as well, which was written by a group of participants in the health domain within GAIAX. So what are we trying to achieve in the health domain? We need to enable technical, semantic, and organizational interoperability of health data. That citizen, the patient, is in the middle of all of that, and there's very many parties who aggregate small parts of the data around that citizen. We need to make that data exchangeable in order to combine it and make better sense and come to better advice for the patient, or to channel that data for secondary use purposes. So we really believe that the concept and the infrastructure needs to serve those dual purposes. Today, we see that infrastructure are very often designed for only one of those purposes. We believe moving forward, we should recombine that infrastructure and design a concept that supports this dual purpose. The care delivery for the individual patient needs to improve. Patient needs to be in control of their data, needs to get faster diagnosis, better advice on a treatment plan, better follow-up in a treatment, actually in order to support the quadruple aim. And the same infrastructure should also support and allow secondary use for better policy making and better research and innovation, as we saw in the slides from the Commission as well. So we really strongly believe that this can be united. With this European working group, we're also not just talking concept, but we're also becoming very practical, and we try to define priority use cases, themes where we can really demonstrate the benefit of these data spaces. And we've aggregated many existing initiatives because we also don't want to start from scratch. There's a lot of good initiatives ongoing. And we've looked through that with a helicopter view and really identified some areas where I believe there is a lot of potential. 3 of them are listed here. One is in the rare disease and the cancer area, where registries, imaging, and genomics really need to be combined. Second, there's real-world data becoming much more important. That's data captured by the patient in the form of measurements, but also as patient-reported outcomes. And third theme is in the area of the medical record exploration. And in each of those themes, we try to make a very concrete application. Just illustrating the first one, in the rare disease area, how nice would it be if we can find the patient like me in a complicated situation? There are more than 4,500 rare diseases. Only 6% are really treatable. 30 million patients in Europe are affected by them, and they typically go through a very slow diagnostic process. How nice would it be if we could find, if we have a difficult patient in front of us, find the patient like me with a confirmed diagnosis, with a working treatment plan, and say, hey, you are probably will benefit from a similar treatment. So if we could do that matching, then we could accelerate the path to diagnosis, treatment, but also the development and validation of new treatments. In order to do that, we need to combine multimodal data. We heard about the cancer imaging initiative, which is very good. That's one of the components. We heard about the genome information sharing, but we should match that also with the clinical and real world data. And it's only the combination of those 3 which really gives us the breakthrough we are after. That's very ambitious, but that is where these data spaces should be designed for, not creating more isolated, but federated and connected data infrastructures. In order to do that, GAIAX proposes a framework, and in that framework, there is room for a number of common enablers. Many of those exist in parts, but need to be made more reusable in a consistent framework. And we see that in this application ecosystem, all developers struggle with very common issues in identity management, consent management, pseudonymization or anonymization of data, but also standardization, too much variability in coding and terminology standards, data normalization, and so forth. So if we would be able to develop these common enablers in a more common framework, they could be reused more easily across players in the European business landscape. So that is where GAIAX is after, and we're doing that collaboratively, reusing existing initiatives, collaborating between stakeholders in our respective domains, and also learning from the breakthroughs in the other domains, being the mobility sector, industry, agriculture, education, and so forth, because not all of these enablers are really health specific, so we can reuse them across sectors. Just briefly, some visionary views about or viewpoints from a Philips perspective. This is probably well known, but Philips is active across the health continuum, because we don't believe a breakthrough needs to be happening in just one aspect of this care continuing. But our solutions cover multiple areas, from healthy living in the prevention area, diagnostic treatment, and the following up afterwards. We try to do this holistically across the pathways, aggregating data, making smart algorithms, and bringing them in really usable applications for our health professionals as well as for the patient, in order to improve the quadruple aim, which you see on the right: improve outcomes, patient and staff experience, while controlling the cost of care. If we always have those four on our radar, we can really collaboratively design solutions along the health continuum. So how would that look in the future if we really would get a breakthrough in our health data spaces? We believe that health delivery can be coordinated much better, centralized at a local, regional, or national level, appropriately, without disturbing the privacy and the rights of the individual, but still, where needed, aggregate the data such that care can be coordinated much better to the benefit of our patients and of our societies. In order to do that, we need real-time and predictive insights at scale, not just bringing the data together, but building applications that let people act differently and more effectively, either the patient themselves, the care givers around them, or the professional health systems. And it's not just about the clinical parts, also the operational optimization. We've seen the challenges with COVID testing, vaccine follow-up and delivery. So the whole operational challenge, overload of intensive care units and hospitals. So the whole operational management is an area where we believe data-driven approaches can improve and bring a lot of benefit. So those are some of the areas where Philips tries to innovate, but we don't do that on our own. We do that in collaboration with many other parties. And for example, in the GAIAX association, we find both small companies and large companies where we try to collaborate and get this to the next level.
Thank you, Bert. Very nice presentation. I would continue with Nicole. Nicole, could you please, yeah.
Thank you. And I want to nicely build on actually what Bert has said. So I want to ask you, what is it that you think of when it comes to a medical emergency, like really a situation that is about life or death? What's the first thing that comes to mind? So normally when I ask this question, right, the answers that I get is, an ambulance car, paramedics, a defibrillator, all kinds of different pictures that pop up in our heads, but I have never heard the answer data, although I'm absolutely convinced that data has not only the potential, but will save many of our lives. And I have two kids. My daughters are 3.5 years old, and I hope that if they ever end up in a situation of a medical emergency, that they will have an ambulance car with a big screen in it, where the paramedics see all the kind of relevant health data as it relates to their person, right? Their allergies, any kind of preconditions, medication. So they know who they're dealing with. But of course, we're still far away from that future state. And I can see that on an everyday basis. So my father, for example, he's in his mid-70s, and as many of our parents, he has a number of preconditions, including diabetes, several cardiac events, and also like advanced cancer. And as someone who's been in healthcare pretty much all my professional career, it sometimes really frustrates me to see how, despite the best intent, his care could be organized so much more efficiently. I'm thinking about, the number of times he has to redo tests because the relevant information is not making it in time from one point of care to another. I'm thinking about how his diabetes and cancer were diagnosed way too late, although there were indications that could have led us down that path. And I'm also thinking about the situations, now between his oncology treatments where he's experiencing side effects that he's not reporting to anyone because he only sees his physician, a number of times in the year. So I'm wondering really how this health management will look like when I'm in his position, or even when my daughters are in his position, because I'm absolutely convinced that by that time, healthcare will seamlessly integrate the domains of science and medicine with technology and data analytics. And this is also what we're trying to do in Roche, by the way, right? We're going way beyond just, science and the development of medicines, but we're also tackling diagnostics and different technologies that can help both patients and physicians to make the right decisions around their treatment. And similar to what Berta said, we're not doing this in isolation, but we're actually collaborating with a number of companies and stakeholders. Some of them are even on the panel today. Berta has also highlighted that this data will give us benefits on two levels. So we will be able to get a holistic picture around a single person, but also it will enable us to get insights, valuable insights on a population level in order to improve health and care more holistically. I am absolutely convinced that this data will already be a game changer for my daughter because her chances of suffering, for example, a cardiac event will be much lower. I'm sure she will run around with her watches and sensors all over her body that will indicate to her that something's not right before a severe event happens. And I'm also convinced that she will be aware of a risk, for example, of developing a certain cancer, not just because of her genomic profile, but also because of her lifestyle. And this will help her, to take her health in her own hands, to prevent, to go into screening programs, and as such, to make sure that her cancer is detected if she develops it early enough that it can still be cured. This data will also be a game changer to us as a society. It will allow us to get, inserts that can accelerate research and develop, solutions for the most severe medical conditions that we're facing in our society. It will allow us, as Berta said, to learn almost in real time from each and every patient and to improve care for the next patient to come. And it will also allow us to identify differences in how patients are treated from one place to another and share best practices so we can improve overall. I guess most of us who are here today would agree that healthcare is, if not the sector that is most imminently going to go through transformative change based on these technologies and data insights. The EU is now luckily moving forward, but slightly lower pace than what we see in other parts of the world. And I know that the European Commission has launched a survey, and more than 80% of people have stated that they believe by sharing their data, their health data, we can improve health and care for the wider population. And they're willing also to do that because they're already doing it in multiple other areas of their lives. But we also hear about the fear, around data security, and I think this is valid, but we also know that we have the means to protect very sensitive personal data as we're doing it when it comes to our, for example, financial information. So I want to close by saying, I'm not sure what my daughter will answer me if I ever ask her, what comes to her mind when she thinks about a situation of a severe medical emergency. But I'm absolutely convinced that she will tell me that, data, by that time, data will make sure that we keep people out of hospital, that we prevent diseases, that we can get the right care to the right patient at the right time. We can organize ourselves more efficiently, and also that we get valuable insights for research and development of new medicines. And as such, I believe that data will not only continue to change our lives, but it will also actually save lives. I'm going to hand it back to you.
Thank you, Nicole, for the inspiring speech. Yeah, I really enjoyed it. And I would like to conclude this introduction with Professor Martinez. So, yeah, the floor is yours for your speech.
Thank you, Francesca. Let me say to Nicole that I would have, when I will be more or less in my 80s, I desire to have a wearable connected to my hospital. And when I feel sick, please, my wearable must call to the hospital. They assign me the correct vehicle. And nowadays, I will have to go to my reference hospital, and in that time, not. I will go to the best hospital for me. That's my concern. But probably everybody is hurried with privacy concerns on that. And that is my speech about, because during this panel, we are obtaining relevant information from different points of view regarding the needs or requirements for research with health data. In our discussion, I think we have been giving you different perspectives related to companies, researchers, and legal support teams. This is my job. All of us must face a particularly demanding legal framework with a level of particularly complexity that sometimes determines clearly defensive approaches by the legal teams. I could share with you my experience on GDPR concern at H 2020 Health Research Project. The main lesson learned is consists on that I would like, I have to work with different national legislations. There are no homogeneous criteria in the regulation of research with health data. It is not easy to obtain data for research. In fact, it is really complex from a legal and administrative point of view. And you know, this is not only regarding laws. The most difficult is to deal with a lot of different criteria from data protection authorities. We have to deal with different soft law. In fact, during COVID disease, I have to apply to my projects. I have to apply in my university, guidance published with brief notices from the DPAs. It has been really demanding. There is a second lesson learned from my participation in European projects such as Big Medalytics. The GDPR compliance duty often becomes the most relevant issue. And yet, don't you think that the common good, the research itself, and the well-being and health of patients should be the most relevant one? Why we have to be concerned by law? Let me state clearly that the guarantee of fundamental rights, that the privacy-driven investigation is indispensable, but the differences between member states in relation to the conditions of data processing operate as a barrier that can only be solved by anonymization techniques and data spaces where processing is done under national law. I could, on the other hand, I would like to share with you how Spain adopted a legal framework that may be useful for the future design of a common data governance framework for health research. Spanish organic law on data protection allows the constructions of data processing repositories perfectly aligned with the objectives of the Future Data Governance Act and probably offers some reference frameworks in terms of data governance. Our standard allows for research with personal data on the basis of consent and includes an exemption for research on the use in data analytics context of anonymized or pseudonymized data. The innovation of the law consists in defining the rules for the use of pseudonymized data. This law provides a set of particularly relevant safeguards. Briefly explained, these are essentially the following. First, research with pseudonymized data requires compliance with the same rules that we generally apply to health research. Therefore, from an ethical point of view, it is essential to obtain the appropriate authorization from the ethics committees. In my opinion, this should be complemented by an ethical impact assessment using the Realtime methodology developed by the high-level expert group on artificial intelligence. It is also necessary to deploy a data protection impact assessment and, as Ber said, to apply the data protection by design and by default strategy. On the other hand, a material isolation is required between the research environment and the controllers who hold in their custody the identifiers that would allow the re-identification of the patient. Secondly, the development of security measures is necessary. In addition, these measures must be addressed to make the material isolation possible. This is where all aspects related to the definition of roles, the attribution of permissions, and the traceability of uses are of substantial value. Thirdly, it is not enough to adopt technical measures. It is essential to define legal commitments on not to re-identify. This apparently very specific clause is the one that clearly drives the need to design data governance models to rule the repositories. It therefore leads to the design of data spaces with clearly defined registration processes for the granting of such permissions, data sharing agreements, and requires ethical, legal, and technical validation of the research proposal. The regulation ends with a re-identification clause in cases where the life or integrity of the patient is at risk. Obviously, in this short space of time, we cannot go into the details of the implementation effort that this legal framework entails. However, we're in a position to affirm that this framework is efficient and its national implementation by Foundation 29 has been awarded by the Spanish Data Protection Agency. I would like to conclude by sharing with you some experience achieved. We are talking about real-world data. Please let me share with you real-world experience. It's really, really difficult to define aspects such as the applicable law on the jurisdiction. And I think you will understand how difficult it is to ask a stroke patient at the door of a hospital emergency room for consent to participate in research. And this is compulsory under certain national laws. Let me give you a second example. We are dealing with anonymization in a case of cancer imaging. We develop a first layer of anonymization, erasing direct identifiers. We develop a second effort, erasing metadata. We are designing a controlled repository. There are no personal data, I mean, but this is not the opinion of the DPOs of Germany or French hospital. Because in their approach, anonymity must be absolutely reversible. Then it is really difficult to work in this kind of environment. I will not expand on the examples. However, there is a lesson to be learned. Regulatory differences between countries create insurmountable barriers that make it necessary to design research processes with pipelines and repositories dedicated to processing data under the law of each country, as Bert explained us. I am referring to environments in which, whether by means of privacy-enhancing technologies or any other procedure, the data will be processed in accordance with national law and shared only for the inferences obtained. And despite this, we have been able to develop truly effective strategies. However, the volume of data available and the quality and reliability of that data is always at risk. If the European Union really wants to build a European space on health data, it must reflect significantly on the need for a common legal framework. The Spanish standard could be a good starting point. Thank you very much.
Thank you, Professor Martinez. Yeah, I see some questions from the audience, so I guess it's time to start with our panel discussions, and I will give the floor to the moderators, Flavio and Milan. Thank you.
Thank you, Francesca, and thank you to all the speakers. Very nice introduction. Maybe if we try to set the scene further, I would try to maybe make a few questions to understand the facts a bit more. Mojca, for example, you have shown us an example from a member state which is very advanced in data collection, right? Also, the primary use of data, I would say it's quite forward. So on the national level, I would not say everything is solved, but it goes in the right direction. So how would you see this, and what would be for you then the main benefit of the European health data space? How you see that?
Yes, so of course the situation is not without any room for improvement. We are not that good, but actually we have a lot to show. And maybe also because we are quite a small country, which is perfect for such a pilots. But what will be the main benefit of the European health data spaces? Well, I would say from the patient point of view should be shifting from the system towards patient-centered healthcare models. And as we are all learning from pandemic experience, which on one hand opened the doors widely to adoption of digital technology, for example, telemedicine and new ways of communication between patient and physician. On the other hand, also revealed gaps and challenges. And Nicole Arming's story already explained a lot since the EU health data space would support actually primary care and of course the development of new treatment medicine services. I mean, all developments aiming to improve access to quality of care and patient outcomes. And in that regard, we have to understand that big data is an integral part of the new generation of health technological developments, and that we have to understand also that big data means data from wider regions, cross-border regions, and what EU health data space will allow is advanced analytics and will provide to the future doctors and patients insights that were not available before. It will be possible to have diagnosis faster and get accurate treatments. It will reduce medical errors, etc., etc., etc. And for healthcare systems, for sure, analytics and those also healthcare analytics have significant potential to reduce costs of treatments when we are discussing, for example, specific diagnostics as rare diseases or cancer or prevention programs. And I believe all regions have limited resources, and that kind of analytics would add significant value. And on the other hand, we are also witnessing the effect of data analytics on strategies for the control of epidemic and prediction of outbreaks. Of course, also here there are rooms for improvement, but I believe quite a number of models were tested, and we learned a lot. The learning curve was exceptional. And when we were discussing the thematic, I opened also one another point. What could be the benefits or opportunities for SMEs, since I'm coming from this range of companies? Because for the artificial intelligence, machine learning, well, the most resources and researches are available from big companies, but main message besides how to overcome challenges is also that another crucial point here is collection of data. And here I would say are endless opportunities for SMEs. For example, end users will always provide data indirectly. We need end users entering data. They must understand, but they must understand that any data entry is necessary, and this is not something that comes naturally to their mindset. We have to understand that entering data for them, for it's also for doctors, for nurses, it's also administrative burden for the healthcare. So there will be always a need for better solutions, automations, improved processes, and etc. And data builds on data. And for effective usage of the data, we need advanced solutions and skills. And of course, also a colleague, Richard Martinez, gave us quite a lecture and lesson with his speech. So in the future, I believe there will be fully customized solutions, microservices for healthcare customers. And so at the end of each stakeholder will be able to process the exact data in the exact forum it needs. This is, well, hope of all of us, I believe.
Thanks much. I think you raised two very important points. One is this sense of collaboration. Maybe we can't say really community, but this collaboration that each
Yes.
actor has to understand what is their role, why are they doing it. We have end users, patients, healthcare professionals. We have SMEs that are in between them and the big companies, right? So this also, we have to see this feedback loop that Bert has shown somehow in action, right? So, and you also, the second thing you mentioned, big data, and that's possible only if we do it cross-border, international. So maybe, Nicole, you have seen it all during your career. Are there already some existing examples where usage of big data helped improve some healthcare outcomes? Can you share something with us?
Absolutely, Flavio. So I think, some of the, examples that Bert was alluding to, they're already becoming reality. And for us, for example, as a company, as we have access to about 2.6 million electronic health records in the US already, and we're drawing insights out of that. So I can give you maybe two examples how we're leveraging these insights. So the first one is, more centered around accelerating research. And as Bert has said, particularly for rare diseases or rare cancers, this plays a critical role because we have very few data points and we need to make sure we bring them together across the globe. And it needs to be said also, right? We're talking about rare diseases or rare cancer, but they're not rare at all because there's more than 30 million people in the EU suffering from these kind of conditions. And what we can already do is, for example, if you put yourself in the shoes of a rare cancer patient where all the kind of standard of care treatment is exhausted, we want to make sure that this patient gets access to exploratory treatments through clinical trials. And we need to make sure that we can find the right patient for the right trial. So this matching can already take place. Secondly, if I'm that patient and I'm, going into that clinical trial, I want to make sure that I actually get the exploratory treatment and not have to go into a control arm where I'm continuing to be treated with a standard of care, right? Which is in some instances probably not even very ethical to do. So what we can already do is that we get the majority of or even all patients in the exploratory arm and use real-world data from this high-quality electronic health record. It takes a lot of time to curate it, to show the comparison and to have a discussion based on that with regulators and payers. The other example, maybe more from a physician lens, is, right, how do we enable the physician to personalize treatment decision? And again, there, I'm giving you the example of a metastatic breast cancer patient who has a severe heart condition, and the physician is not sure whether or not to treat the patient with a certain medicine. So very often we don't have that insights or data from our clinical trials because those are not typically the patients that are part of clinical trials. So we have access to this database, and out of the more than 17,000 patients, we could identify more than 30 that were in a very similar state to that metastatic breast cancer patient with a precondition in the heart. And we could show whether there was any additional safety signals, yes or no. So that's the type of insights that we can already generate. But as we said, in Europe, there's no database that's big enough actually to go down that route. But in other parts of the world, there are already.
Mm-hmm. Okay, thanks. You mentioned high quality medical records, and I was positively surprised to see also in Kerry's presentation that even at the political level there is this awareness that we need first of all high quality data. So maybe Kerry, about how would this new legislation support this collection of high quality data, and maybe in this context I would like to raise a concern from our public. There was a question about HL7, where there is the concern. So it's a standard that's well established, used. Is the Commission going to extend, to reuse this and other standards, or are we going to have yet another new proposal of dataset structure? So maybe Kerry, if you could comment that. And also Bert, as you're active in GAIAX and other associations. I mean, they're not standardization bodies, but they're concerned a lot about standards, right?
Yes, thanks a lot, Flavio. I'd just like to make a couple of general points about data quality as I see it. I think, first of all, I think it's worth pointing out that when we're talking about data quality, I think it's going to be a journey. It's never going to be a destination. I don't think there's any point at which we're going to say, okay, we've got sufficient quality now, we can stop making improvements. So, we're at some point on the curve and we want to get further up the curve, and that's always going to be the case, I think. Right now we may be quite low down the curve, but with a long way to go, but still. And then I think the other point I want to make about quality is how important it is that we have these discussions between the different stakeholders. I'm thinking particularly us in government with the users of the data to tell us what sort of quality they need, because fundamentally it needs to be fit for purpose. And so, it's inextricably linked, the notion of quality, to what its purpose is. And so it's very important, I think, that we have a good dialogue on all these kinds of topics, which we do in various forms. So yeah, I mean, and as I mentioned I think there are various aspects on quality that we're looking to promote, whether it's through legislative means or through investment means and support. So one is sort of this notion that the data is fair, and the FAIR principles, and there's a lot of work around the FAIR principles. And we can see what can we do in the legislation that promote that, and that's something that we're looking at. And I think the other issue, of course, is around the standards for interoperability. Again, this is the work that we have ongoing, that we kicked off with the Commission recommendation in 2019, and that once we have consensus technical standards in place, we need to see these taken up. So what can we do to incentivize different actors, whether it's public authorities or whether it's actors across the landscape, to take up these specifications. So we'll be looking really in the process of how we can incentivize this and how we can support that as well. And it's not just in the legislative proposal, it's also going to be in the kind of investments that we're making as well, through digital and through EHealth and these kinds of programs. On the specific point about I think the question was particularly around whether we're going to come with something new on the technical specifications. I mean, indeed not. I mean, if you look at the whole point of the exercise is we're trying to get 27 member states really together to come up with a consensus. So what they're doing to do that is they're looking across and seeing what's available, what are we already using, what's the best fit, what we need. So if you look, for example, at the recommendation in the annex, where we set down what there already is, this is very based on HL7, for example. And these standard sets of HL7 in particular, for example, are very much part of this EHealth project and are there to inject all the knowledge and experience and know-how that they have and what they, what they've already come up with. So it's not about coming up with anything new. It's about a consensus on what there is and what everyone can be using. That's the principle, and that is already quite time-consuming to do this kind of work.
Yep. Can you imagine? Bert, maybe if you make a comment also how...
Yes, I can build on that. So indeed, but policymakers are busy with it, both at the Commission, at the member state level, but typically they ask the opinion of the specialists in the domain again. And they are typically member of committees and standardization bodies, and then there's whole communities behind this. And our concern is indeed in the industry that we don't converge enough. There's too much divergence still between various localizations, even within HL7. We have profiles and implementation guides and localizations and SNOMED localizations, which are picked up at different paces. So even with the existing dominant standards, there is still too much fragmentation going on. So we should really collectively avoid that and team up to converge rather than to diverge. And for sure, don't come up with yet another standard. If we have enough standards, we should converge the existing ones and have a model in place to manage the localization. Because localization is required to a certain extent, but we need to manage it collectively, either through the committees, either partially also through automation, because some translation between codes and terminology services can also be automated, and let's do that. One additional dimension on quality, I think, is quality is made at the source, at the time the information is keyed in by clinical professionals, but also by the patient or their caregivers themselves. And these people do that with quality only when they get something in return. So we should also make sure that these people who need to enter data understand why that field or that code is important, why it is used, and preferably that they have a return or a benefit when they do that accurately. I'm very motivated to have my COVID test administered correctly because I want to use it in my COVID pass. So people need to be motivated in order to create quality. It's another very important guidance.
And Bert, is there maybe, because we have seen now from, I think, Nicole, Richard as well, about, let's call them wearables or consumer devices that there is this wish to integrate them in the healthcare system. So how can we ensure quality there? Because this is tricky. It's often even,
yes,
standards and so on. Yeah?
We're clearly also on a journey there. People don't know typically yet how to use a constant heart rate measurement with a smartwatch days and months and years, and what to do with that signal. People don't really know yet. But there is potential in trending information over time for sure. So people will want to find a safe way to share that home-based measurements, that real-world data. We believe collectively there is potential, but we will still need to learn how to interpret it. We should also not be afraid of the data by itself. Yes, it's massive data, but it will only become meaningful after processing and turning it into insights and recommendations, which we can then validate from a scientific perspective, avoid false positives, check for false negatives. So these methods, the use of such real data needs to be properly regulated and controlled and validated, and then it can become a very useful asset, which we want to combine with the other data we have.
Yeah, I think this partially answers also a question from the audience about not overwhelming users or patients with the mass of data. I mean, I already know when I get a lab result from my doctor and I see this red and green stars, until I don't see my physician, I'm all worried, and then she says, "I'm not worried. Don't worry. It's it's fine."
It would be better to get a clear recommendation
Right.
on that form, on top of just the numbers.
Yeah, that's it. If we move to another topic, to still to this primary level, we have we see mostly data spaces, of course, at national level, but there is this cross-border dimension that pops up, right? So how is this? How are data spaces really going to improve cross-border care? Kerry, what's the vision from the Commission? What's going to be done there, or what are going to be the benefits?
Yeah, so I think, I mean, obviously, from the citizen perspective, it's about enabling the citizen to be able to access their data wherever they are in the EU, or having a mechanism whereby a treating physician, so a citizen will be able to share their data with a third party in another country, for example, or if you have an accident in another part of the EU, you could easily access your data. And this is infrastructure that's already in place. And I think the European Health Data Space will be looking to how this can be improved, this situation. And of course, so that's the fundamental way, I think, in which we are supporting access across borders from a citizen perspective. And of course, this is all backed up with corresponding work on security and identity. So work around, for example, how to ensure that this data is accessed in a secure way. So we came, for example, with a proposal recently on a European digital identity regulation, which includes provision for member states to offer a digital wallet to citizens where they can use to store different kinds of data. And of course, health data is one of these kinds of data that could be stored. But then, in seeking as well to tackle the obstacles between how digital services are able to transfer from one country to another, this is also a mechanism. So you enable, for example, successful telemedicine services operating in one country to be easily set up in other countries, and that's just an example. So, in that sense, as a patient, you will be able to access good quality services across the EU. And of course, fundamentally by putting in place strong governance to really increase this, the way in which the data is moving, the speed with which data is moving, the volume of data which is moving. So I think obviously it's fundamental both to the primary and secondary that the governance is set up well, that there's trust in the system. I think that citizens feel their data is secure and well protected. Otherwise, they simply will not want to engage with the system and to see their data. So it's really about the infrastructure and the governance and the cross-border linkages and ensuring that there's the hurdles around the barriers to moving the use of digital tools and services, and the fragmentation is reduced. And all this will benefit, I think, data access across border.
Nicole, you gave us your personal view also earlier. So, and I know your personal life is split between different countries. So, how do you see this benefit? What would be the benefits of this cross-border data?
Yeah. Thanks, Flavio. I agree with everything that Kerry said, and I think there's not much to add other than, I mean, as you said, we're all citizens of Europe, and for many of us, the borders are existing on paper, but not in our day-to-day lives, right? And I think we, as an industry, we do observe great inequality between, access to diagnostics, to treatments, but also, in particular, to expertise across countries. And I think, bringing this data together will make it easier for patients to seek advice, also like a second opinion. And it will make it easier for us to have cross-country expert consilience when it comes to difficult patient cases, but also to learn from countries that are particularly in the forefront of treating certain diseases. What can we learn from them to apply in other countries to reduce that inequality? But I want to maybe also double click on one point that Kerry said, and that I saw as a question coming from the audience, in terms of how to adjust data quality to the use, because I think that's a very important point for people to understand. If we want to use real world data for research purposes, right, to train algorithms, for regulatory purposes, right, to get medicines approved, or for giving treatment decisions, then we cannot compromise on the data quality, right? We don't want to make these type of decisions based on data that's inaccurate, inconsistent, or incomplete, or not, interpretable. And as the question was coming in, I saw it now on the chat, right? For us, we see firsthand now how much work it is to upgrade this data to a standard that it can be used. Some of it can already be done through automation, through extraction, language extraction. But still, at this point in time, a lot of it is manual curation of the data, and you need an army of really skilled abstractors to get the data from the raw state to the state where we can use it for research purposes. So I just wanted to double click on that point because I think it was really valid.
Time is flying. We have just 1 minute more, maybe Francesca, if there is.
I would thank you, everyone. I would like to conclude by with the final legal statement from Professor Martinez. Maybe you can give it your final hint. And there was also one question from the audience on how do you imagine escaping from GDPR by anonymity? So you can combine both. Yeah, you are muted. Sorry. Thank you.
Really short. 1 week ago, a representative of the European Data Protection Supervisor told us in Madrid that the standard for a Data Governance Act will be GDPR. It means that we will have to deal with different national laws. It means that we are processing data at local level and sharing results, not data, inferences, not data. And nowadays, we're dealing with a new paradigm. We built this right under consent idea, under the idea to control the state, but now we are demanding from the public healthcare services a lot of new ways to give us the public healthcare service. It means that we need to process data, and we need to change the paradigm from consent and this kind of fear in front of the state with traceability, security, and auditability. We have to protect patients and persons with these new tools, not only with consent and not only with different national rules. We need a new way to approach to that in order to provide the common good of people. And I think COVID disease show it to us very clearly.
Thank you. I would like to thank all the speakers and keynote for this very nice session. Yeah, we can close the session now. Thank you, everyone.
Thank you.
Thanks.